Hello, I am Chung. I'm working as a pediatric cardiologist in Sejong General Hospital. I will introduce you 2 cases today. Here is the first case of PA IVS. The patient visited our hospital on the day of birth due to cyanosis and loud murmur. PA IVS, moderate to severe RV hypoplasia, and left PDA were diagnosed via echocardiography. But he was discharged because his parents insisted. But he revisited our hospital at the age of 4 months. He received the first cardiac catheterization. This table is a summary of the patient's long history. I will show you this table several times more during the presentation. The first catheterization revealed pulmonary atresia with bipartite RV. At that time, various tricuspid valve annulus measured 14 mm, valve opening measured 4.5 mm. This is angiogram taken during the catheterization. The first this is the first question. If you are the physician carrying this patient, what is your plan? Are you willing to decompress this RV or abandon it? Yeah, this is a voting session. And the first option is yes, and the second option is no. Yeah, please vote for the option you agree with. And please press voting button in your monitor. And the voting is processing. Yeah, please wait a moment.
Show the CAS result to help the decision?
Yeah, pardon?
CAS data, would you show the CAS data during voting?
Ah, yeah, okay. Yeah, please show the result. Yeah. Yes, number 1, yes. Okay. Yeah.
Wow, 100%. It's amazing. I saw that this patient has severe tricuspid stenosis on the CAS report. In that case, all the doctors voted for RV decompression. It's amazing, I think. Okay, go ahead, please.
Yes. In our center, we also agree with the yes. So after the first catheterization, he underwent pulmonary valvotomy using MIS technique. This is a summary of the operation. The surgeon performed pulmonary valvotomy, left modified petition, and PDA ligation. 5 months after the first
operation. I have a question here. And to the panels, all the doctors satisfied with this approach? I mean, the thoracotomy and maybe closed pulmonary valvotomy, is it enough for RV decompression?
It's Song Kim. I have a question.
Yeah.
How do you evaluate the coronary circulation in this case?
Yeah.
Please answer the questions about the coronary question. Coronary circulation.
Coronary circulation. No, there is no evidence of the RVDCC.
Okay, is there any surgeon about this kind of thoracotomy approach to decompress RV? I'm some worried about this kind of approach because that approach usually do not decompress RV enoughly. The RV muscle resection is impossible. So that's what I'm worrying. Okay, please go ahead.
5 months after the first operation, we did the second catheterization for his progressive cyanosis. Aortic saturation was 74%. RV didn't grow significantly. RV pressure was same with LV pressure. The pressure gradient between RV and PA was 66 mm mercury. TV annulus measured 10 mm, but TV opening was only 3 mm. This is the angiogram. taken during the catheterization. We decided to perform the second operation. We did RV overhauling. This is the schematic diagram of the surgical procedure. Transannular RVOT relief, infundibular muscle resection, tricuspid valvotomy, mobilization of papillary muscle, coda, and BT shunt half closure were performed. 2 years later, his cyanosis progressed and he was smaller than his peers. So he was given another cardiac catheterization.
I have one more question here. So the catheterization between the second catheterization and the initial operation is about 5 months, and is it enough to evaluate RV growth, or should we do evaluate or do something earlier, or we can wait longer? What do you think about that?
It is a very difficult question. But the patient's age was about 10 months. So when we consider the potential of the RV growth, the age is enough to evaluate the RV growth, I think.
Yes, so what about the opinion from the panels?
Yeah, I would have waited with cath, but I understand when you look at the time where this patient was taken for surgery and evaluation, it was in the early 90s. So I understand that there were different decision-making and scenarios I have to respect. But from my point of view today, I would have waited longer for another cath.
Is there any different opinion?
In 1994, in Sejong General Hospital, our surgeon, Dr. Han, just has a training from the Rosomy and came back. So he preferred to using Rosomy's technique in PA IVS. But at that time, balloon valvuloplasty is also tried at that time. But maybe balloon failed and the surgeon made Rosomy's technique. Its advantage is during the pumping, not cover bypass, just made a shunt and on the MPA, and before attaching the shunt with a knife, make a hole in the pulmonary valve. But the problem is RV pressure was not so decreased using that method, and as time passes, RV hypertrophy may aggravate. In PA IVS, even though the bipartite RV, infundibulum is very important for the repair, but the infundibulum getting smaller. So as moderator pointed out, the RV overhauling time at the 14-month age may be too late, right? So I think so. So nowadays we usually perform at 6 months. So there's some difference at that time and then nowadays.
Okay, I understand the situation.
Yeah.
Go ahead.
Okay, sorry. So to respond to Omar, I think our surgeon usually prefer for the study to be done earlier on rather than we wait a bit too long, because I think the surgery a bit more complicated when we wait a bit too long. So they prefer if any intervention to be done early as about 1 year of age.
How early do you do that?
Again?
How early do you do the second, more aggressive RV decompression? How long wait do you?
About 1 year old.
1 year.
Yeah.
I think actually at our center we consider that the second intervention about usually at the age of 3 months. I think it's
Yeah.
early intervention
So you
would be
mean
better.
after
That's
the
what I think.
successful balloon valvotomy?
Yeah, usually first intervention is
Valvotomy at the neonatal period and alveolar overhauling at 3 months.
yeah.
Can I say something?
Okay.
Like we learned in our area that if you decompress the RV early, which you should, in case you think you go for biventricular repair, we started to give ACA inhibitors and alpha blockers, believing that this will improve the RV compliance, because we believe, like most of us, that the RV hypertrophy makes a very stiff ventricle. And you give this medication, we discovered, and we published this in 20 patients in cardiology in the young, like 10 years ago, that the compliance obviously improved, measured by reduction the right to left shunt at atrial level. So our policy is more like do decompression, give ACE inhibitor, and wait for some time to see whether it will affect the compliance positively or not. Of course, it doesn't work all the time.
Yeah, thank you for your comments. Are there any doctors who have a similar experience? Dr. Galal mentioned. Okay.
Unfortunately not, I'm sure of that, because it came from our area. So, many will not imitate, but I know some of my colleagues did it. But anyway, I'll wait another 10 years and some people might do it.
Okay, thank you for comments. Please go ahead.
At the time, RV was still small with 1/3 to half of normal volume, and TB annulus z-score was -3.7. RV EDP was 12, and mean RA pressure was 9, but there was no significant pressure gradient between RV and main pulmonary artery. As you can see, pulmonary artery pressure was relatively low. This is angiogram, and during the study, PFO occlusion test was performed. After balloon occlusion, aortic saturation was increased from 82 to 92, and blood pressure remained the same. And on the other hand, our right atrium main pressure was elevated from 13 to 16. And QP increased and QS slightly decreased. As a result, QP-QS ratio rose to 0.9. As TPG was elevated, pulmonary resistance increased a little. This is the second question. What is your next plan? Do you still want to use the RV? Please vote again for the option you agree with. Number 1 is 1.5 repair, and number 2 in Fontan operation, and number 3 observation with medical therapy. Please vote. And
While awaiting the voting result, do you have any pressure measurement during the catheter study, like SVC pressure during the occlusion of the PFO?
Next, please. Next slide. Yeah, here we can see the RA pressure during the PFO clot. Yeah, first one.
Yeah, please show the result. And number 1, 66%, and number 2, 33%. Yeah. Okay. In our hospital, we concluded that TSRV could not support biventricular circulation, and PFO occlusion was an acceptable option for his cyanosis with little expense, so we carried out the third operation. The third operation was 1.5 repair. The surgeon made anastomosis between SVC and RPA and closed the PFO with primary closure. Postoperative CVP was 14 to 18. Regrettably, early postoperative follow-up data was lost, so this is the earliest postoperative echocardiographic information. 5 years after the third operation, RA was mildly dilated and tricuspid regurgitation amount looked grade 2, and PR was mild, but interventricular septum showed paradoxical motion. Otherwise, there was no significant abnormality. When echocardiography was repeated in the next year, right atrium dilatation and TR progressed a little more, and PR worsened much more. RV cavity looked dilated. So we gave him additional diagnostic catheterization. RV EDP and RA pressure were still high, but this time, LV EDP was also high, unlike previous data. Angiogram, BCPS flow was evenly distributed. And MPA angiogram showed both good both pulmonary arterial beds. RV enlarged compared to previous angiogram, but PR and TR also significantly increased. IVC flow seemed to be disturbed by high RA pressure. LV contractility looked good, but septal motion was decreased and paradoxical. After the catheterization, we discussed the two options, Fontan procedure versus PVR and TVR. We decided to perform PVR and TVR for the next intervention and postponed it because the patient's clinical condition and performance status were good at the time. Between 2003...
So I want to ask to the panelists, and do you all agree with the observation policy or do something here? I want to ask the panelists. Oh.
My impression is, as these patients will need multiple intervention and surgery, I tend to be conservative and go clinically. And if they do well, the situation acceptable, I would always postpone the next intervention because these children will go through a lot of surgeries and intervention in their life.
Good.
For me, I think one of the good investigation that we can do now is actually cardiac MRI, which you can assess the volume, compliance of the RV. That will be a very good, I think, indicator before we decide on any further intervention.
Yeah.
So for this patient, I would proceed with a cardiac MRI before any interventions offered.
So do we have any MRI data or the tissue Doppler image or other functional data at that time?
Unfortunately, the echo data were all lost, and the MRI wasn't taken. And at that time, cardiac MRI was possible, and even the age was very young. So if we have to, we willing to take MRI, we have to sedate the patient. But at the time, we can't do that. So yeah, the MRI was firstly taken at his age of 19, and I will show you later.
Okay. Thank you.
I got one question, Satoshi speaking. So I think it's because of the CAS data, so RA in the pressure almost equal to the RV pressure and almost equal to the PA pressure. So the matter is, this RV can contract to generate forces. So if not, I think we can just give up like an RV. But I think if RV can generate forces, so then we can consider for like which is the worst, PR or TR. So maybe the intervention should be on the basis of these findings. So how do you think about this RV in a performance or in this stage?
Can you answer I think the presenter is not the doctor who cared the patient, and the data was an old one. I think it's difficult to answer. Any more answers? Okay, please go ahead.
Sorry. Yeah, I will go ahead. And yeah, between 2003 and 2010, he was followed regularly at the outpatient clinic. Moderate to severe TR persisted and RA size progressively increased. Pulmonary regurgitation was also free PR. RV function decreased progressively. I will show you several echocardiographic images taken during this period. This echo was taken 3 years after the previous catheterization and 9 years after the 1.5 repair. Free PR, moderate TR due to poor coaptation, and severe RA enlargement are seen. Although RV enlarged, it was still mildly hypoplastic. The contractility of RV looked not bad. The ventricular septal motion was paradoxical. This was consistent feature since 2002. IVC was engorged and not collapsed by inspiration or sniffing. 1 year later, follow-up echocardiography showed similar findings except RV dysfunction with apex bulging. Additional 2 years later, RA enlargement progressed more. TR and PR were still moderate to severe. RV contractility looked fair, but apex bulging was observed consistently. Let me show you cardiopulmonary exercise test results, which were obtained during the same period. This test was performed at the age of 14 years, that is 11 years after 1.5 repair. The result indicated exercise intolerance. He worked up to maximal effort with RDR more than 1.1, but maximal workload was only 8.1, and max VO2 was 56% of predicted value. High VEV CO2 slope also indicated decreased ventilatory efficiency due to heart failure. After this period, the hemodynamic status was reevaluated by cardiac catheterization at his age of 17 years to plan further treatment. RV EDP, RA pressure, and LV EDP were still high, and pulmonary artery pulsatility decreased. RA, IVC, hepatic veins were dilated. Hemodynamic data were calculated as showed. This LV angiogram, LV lateral wall contractility looks good, but at AO view, septal motion is paradoxical. Both pulmonary artery vascular bed were preserved well. BCPS flow was okay. RV volume was grown, but still relatively small. Significant PR and TR were visualized well. RV contractility seems not bad. IVC and hepatic vein dilation and prominent reversal flow were observed. Hemodynamic data and valve functions were worrisome. However, we cautiously planned regular follow-up with appropriate evaluation of TR, RV function and volume, RA volume, and functional status because the patient was asymptomatic and doing well. The patient firstly took cardiac MRI at his age of 19. As you see, RV volume increased significantly compared to neonatal period. Ventricular septum showed paradoxical bouncing movement as observed in previous imaging. Initially, bipartite RV looks like tripartite ventricle, but in this view, RV general contractility seems decreased, and regurgitations through tricuspid valve and pulmonary valve are remarkable. RV was nearly normal looking. After processing, RV ejection fraction measured 41%, and LV ejection fraction measured subnormal. Because of significant TR and PR, the effective RV ejection fraction was estimated at 28%. Since the MRI was taken, several exercise tests were performed for evaluating his functional status and associated symptoms. When he was 19, his maximal VO2 corresponded to 67% of predicted value. This was a little better than previous one, but VE/VCO2 slope was not significantly improved. At his age of 21 years, the the maximal VO2 slightly decreased and was compatible with 61% of predicted value. During this test, his maximal workload reached only 8.3 meds. Interestingly, during this period, the electrocardiogram gradually changed. In 2010, at his age of 16, QRS duration was about 100 milliseconds. In the next year, however, the QRS duration was prolonged to 110. And another 1 year later, RBBB developed and QRS duration was more prolonged to 126. And in 2015, at the age of 21 years, QRS duration measured 130. Around the same time, follow-up echocardiography was a little different from previous exam. When he was 20 years, not only moderate TR and severe RA enlargement, but also reduced LV ejection fraction measurement was detected. In 2015, severe TR was visualized like this. And both ventricular dysfunction was more evident. Consequently, cardiac catheterization to plan further treatment was scheduled based on these concerns. First, severe TR, severe RA enlargement, and both ventricular dysfunction were gradually progressing. Second, QRS duration was getting wider. Third, exercise tolerance was insidiously worsening. So, in 2015, when he was 21 years old, he underwent 6 catheterization. Now, the CAS data. You may think the pressure data resembles that of one-time patient. RA pressure and RV pressure are almost same, which measured 11 to 15. Pulmonary artery pressure lost its pulsatility and also measured around 10. Although LV EDP was lower than previous value, but QP and QS significantly decreased to about 1.5. This is LV angiogram and main pulmonary angiography and right ventriculography. And liver sono was also done for the first time. It revealed severe fatty liver and engorged hepatic veins with coarse liver parenchyma. This is chastity image, which was taken at the same time. Now, let me ask you a third question. What should we do at this point? Number 1, conversion to Fontan. Number 2, TV surgery. Number 3, PV surgery. And number 4, 2+3, and observation with medical therapy. Please vote for the options you agree with.
During voting, I have questions. The MRI and the echocardiography shows progressive left ventricular dysfunction also. So what do you think about the cause of LV dysfunction?
Simply, as I think, it can be, depends on the ventricular interdependence. Well, the RV progressively dysfunctional, so the LV at last was affected by the RV. So interdependence can lead to the LV dysfunction.
Yeah, I personally, I agree with you. And considering that judging from that the progressive LV dysfunction and QRS duration prolongation on ECG, and from those findings, do you think I have another thought about the intervention time in this patient?
As you mean, the time is
earlier intervention before LV dysfunction.
I agree with it that when I prepare this, I think the same thing. So if the patient received the earlier intervention, the outcome may be somewhat different. Yeah.
Any more comments about?
And I have some comment because I have problems voting.
Okay.
Probably because I'm very far away.
Please show the result.
I would not have chosen conversion to Fontan from the start because he already has dysfunctional liver. And we know that one of the problems of long-term Fontan is his functional liver. So for me, Fontan is out.
Okay, and what was the number 1, number 3, number 4? So would you show the initial questions? I cannot remember the number 1.
Number 4 is the first, the most option, and the number 4 option is TB surgery and PB surgery.
Okay, what was the number 1 and number 3?
Number 3 and PB surgery. Number 1, the Fontan conversion.
Okay.
Okay.
Okay, please go ahead.
Yes. After long discussion, we eventually decided to keep using RV as a half ventricle for pulmonary circulation, so we did TBR and PBR in 2016. Both tricuspid valve and pulmonary valve were replaced with tissue valves. In addition, RV overhauling and AS recreation were also performed. 3 months after the operation, both prosthetic valve functions were good. RA enlargement was improved a little. Although RV apex bulging was observed more prominently, both ventricular function looked fair. 2 years after the TVR and PVR, cardiac MRI was repeated. In this image, RA looked still large, but was smaller than before. And paradoxical septal motion improved somewhat, and both ventricular contractility seemed okay. Significant TR and PR were not observed. LV looked good. However, RV and LV ejection fraction still measures abnormal. How do you predict the prognosis of his RV and prosthetic valves? In fact, unfortunately, both valvular degenerations developed so earlier than our expectation. Only 3 years after the surgery, mild TS, grade 2 TR, mild to moderate PR developed. Artery enlargement worsened again, and RV apex bulging and thinning with dysfunction were also notable. Exercise tolerance was also affected. 1 year after the first surgery, his exercise tolerance seemed improved a little. VO2 max was 67% of predicted value, but after 2 years, the VO2 max dropped to 53% of predict, and 4 years later, it dropped to 49%. And even paroxysmal AFib at stage 6 in recovery phase. So we recently reevaluated him thoroughly using various studies, including catheterization. PR seemed more than moderate, and TR was also significant. RV contraction was not good. RA pressure, RV EDP, and LV EDP were not significantly high compared to before, but the cardiac output was quite low. This is pulmonary angiography showing severe PR. Though the catheter rebounded into the RA, significant TR is observed well. This is current ECG. The rhythm is sinus rhythm, but RBBB and LPFB and borderline PR interval are identified. There was no significant arrhythmia except infrequent supraventricular ectopy during Holter monitoring. In echocardiography, RA seemed more enlarged. RV apex bulging and RV wall thinning were still observed. Mild TR and TS remained, and PR looked at least moderate. LV function seemed relatively fair. In MRI, similarly to echocardiographic finding, severe artery enlargement and RV thinning are demonstrated. LV looks fair, and RV wall generally became thin. RV is mildly dysfunctional. PR seems more than moderate.
Can I ask something
Okay.
in regard to MRI?
Okay, go ahead.
I'm not very good at reading it. That's why I'm asking the specialist. I noticed that the RV muscles in the apex is very thin. Does this have something to do with the overhauling done to the RV? Number one. 2, if we have an overhauling, does MRI indicate poor function or explain it to that poor function of the RV?
Would you answer, or our surgeon, Dr. Chung, can also answer this question.
Actually, I did RV overhauling, but at that time, I thought I didn't resect too much muscle. So after first of MRI showed still RV volume is not big. I think. I don't know exactly why the RV wall is thinning. Actually.
Yeah, I also found the degree of tricuspid valve relaxation and PR degree and RV function is variable according to the studies. I think that's somewhat strange. Anyway,
Yep.
please go ahead.
Yep.
All right, I'm sorry.
Yeah.
So basically, because I would like to go a bit retrospectively, because when we look back before the double valve replacement, both tricuspid valve regurgitations and pulmonary valve regurgitations look significant. But again, on the tricuspid valve regurgitations, it's probably due to functional RV because of increased RV volumes because of the PR. So when there is a replacement of the tricuspid valve, make it tricuspid valve more competent. So that is probably the reason why the RV now become very poor compliance and function.
Okay.
So I think there's a paper, I can't remember the author, post Ebstein repair and had failure of the tricuspid valve and then replaced with prosthetic tricuspid valve, and patients develop RV dysfunction after the replacement.
Okay. Any other comments?
So go back to the option, and I would prefer to replace only the pulmonary valve. Sorry.
Only the pulmonary valve. Okay. Is there any other comments about this mention? What about the surgeon? Okay. Please go ahead.
Last MRI processing data, RVEF and LVEF measured 46 and 49% respectively. PR fraction was estimated at 24%. Lastly, I will show you the serial cardiac MRI data and images altogether to compare those intuitively. First of all, this is a table comparing the volume and functional data. 3 MRIs were taken at similar body size. RV-EDV decreased after TVR and PVR in 2016, but more increased again lately, and the Z-score were consistently below the -2, and RVEF seemingly increased a little over time, but we have to consider the reappearance of PR. Only LVEF seems to improve through this period. Serial cardiac MRI images with thin view are presented. Okay. This is my last slide. I want to listen your opinion on these questions. Please feel free to express your thoughts. Can we think the patient's current condition is good? If not, what can we do for the patient now? Can we think all the interventions conducted were the best ways for the patient? If not, when and what should we have done? Actually, as we think the problems of this case are ongoing, we are willing to accept all the productive discussions.
Oh, yeah. During voting, is there any questions or comments?
Actually,
I'd like to comment.
while we have a conference before TVR by valve replacement, the pediatric cardiologists recommend the Fontaine operation because the physiology in cardiac cath for 3 times is just like a Fontaine physiology and the low cardiac output. So the one thing is PR, TR is the energy loss, and the slightly dilated RV influence to the LV contraction, paradoxical movement. So if the RV did not work, then LV function improved and the hemodynamic may be improved, cardiac improved. So we recommend the Fontaine operation, but the RV apex is at that time is the muscular. So the surgeon want to surgery once more to make volume more to the apical area. So TVR, PVR, and apical scooping was performed. Initially, the patient shows good because volume loading is decreased, the patient shows good. But as time passed, the valve degenerate and the regurgitant flow again, and LV function decreased, so the patient was not so good. So we discussed again and recommend the Fontaine operation again, but one more time, the valve repair. So we will have interventional PPVI and the thorax valve, percutaneous thorax valve implantation next month. It's our Sejong's decision. But I think it may not work long, so sooner or later the patient needs the Fontaine operation.
I think in this patient, the Fontaine operation has a somewhat risky because the patient already have left ventricular dysfunction, so not good candidate for Fontaine operation maybe. Any other opinion from the panels?
I believe also
Dr. Galal?
that if Fontaine operation, it could have been done earlier, because obviously the biventricular problem, though at that time, I have to say I commend what the colleagues did, and definitely they improved the quality of life of this patient, no doubt. At some stage, we have always to rethink. Biventricular is always good in some patients, but sometimes you have to change direction to single ventricle. Today, to do Fontaine, as I said before, because already functional liver, I think it's a high risk.
Yeah. Dr. Song-Hye Kim, do you have any
Yes.
comments about that?
I have one opinion. I have one recent experience. I brought my high school patient the same situation to the TCPC conversion this week. He was had RV overhaul and 1.5 repair, and he was in very good, fair condition, but his hemodynamics appeared that the the elevated A wave on the central venous pressure, but it is as low as 10 millimeter mercury, and in the MRI, the pulmonary artery diastolic forward flow. That means there's a dysfunction of the RV, even though the adequate size of the RV overhaul. So I always have been suspicious about the effect of RV overhaul, which can dilate the volume, the RV, but that does not always improve the RV function, pump function itself. So systolic function and as well as diastolic function. So in that case, he began to progress liver dysfunction on echo at the beginning. So I recommended the patient and the parents to TCP's conversion, even though he has a bare condition. I had some difficulty to persuade it, but the early re-intervention to Fontaine maybe contribute to.
In that patient, how did you deal the sizable RV during the TCPC conversion?
Yes, I did everything, MRI and dialysis catheterization and echo. So that evaluated the RV diastolic dysfunction and as well as the LV and RV ventricular interaction is not good for LV function. So at the same time, to TCPC conversion, we recommended our surgeons to partially close the tricuspid valve to reduce the RV volume to avoid the effect to the left ventricle.
Okay, thank you for comments. And can you have the vote result?
이건 no vote. Yeah.
Okay, so we have seen the 27 years of clinical course in just 30 minutes or 40 minutes. Okay, we always learn from, Yufai Chung.
Yeah.
Okay, we want to hear your opinion.
Yeah, thank you. I just want to comment on several things. One is about the use of the RV overhaul in patients with hyperplastic right ventricular PA IVS. Although this has been advocated, say, more than about 20 years ago by Roger Me and then the Royal Children, over the last 10 years, actually there's been a shift in the management, even at Royal Children, because the intermediate and long-term results have shown that, as mentioned by Dr. Thinh earlier, it's not only the size that matters, is that to increase the size, the right ventricle, it doesn't work as a pump or as a filling chamber. Okay, so that's the reason perhaps some groups are moving away from right ventricular overhaul to direct adoption of a univentricular repair pathway. That is my first comment about right ventricular overhaul. Now, the second comment is on the present management, as Dr. Sejong mentioned about his concern on the transcatheter management of the tricuspid valve and pulmonary valve. It seems to me that even with complete abolition of the pulmonary regurgitation and tricuspid regurgitation, this young lady may still suffer from several things. One is right ventricular systolic and diastolic dysfunction. Two, there is adverse ventricular-ventricular interaction, thereby causing left ventricular dysfunction. Three, there might be progressive right atrial dysfunction and liver dysfunction. We have seen patients in our recent series up to the age of 40 to 50 something years old, developing liver cirrhosis as a result of liver congestion. So therefore, I also share the concern of Dr. Sejong that despite the transcatheter valve intervention, we still need to monitor the patient closely for the ventricular function, both on the right and left side, the exercise capacity, atrial arrhythmias, as well as liver dysfunction. So eventually, this patient may still require a spontaneous conversion.
Okay, thank you for your comments. And
May I have a quick question to the panel?
yeah,
All right. Because I admire Hyun cardiothoracic work. So during this RV overhaul surgery, so how much basically you are allowed to remove all this RV vascular cavity?
Oh.
So how extensive, how much, I don't know.
yeah. Can I say?
Hyun?
Maybe this question to Dr. Yun? Dr.
Yeah.
Taejin Yun.
Can you hear me?
Yeah, we can hear you and you can see you.
I think RV overhauling is not eliminating all the muscles in the RV. It's just elimination of the RVOT obstruction. So it should be minimalized to not to jeopardize the RV function. I think this patient has several points. I want to ask all about what if the patient had first intervention immediately after birth rather than 4 months of age? What if the patient had undergone 1.5 repair with the ASD left open rather than closing the hole? So what if the patient had mechanical double valve replacement rather than tissue valve replacement because the tissue valve failed very fast, and actually that is a little bit anticipated when you put in tissue valve in dysfunctional RV. And I think the patient would undergo heart transplantation sooner or later rather than undergo fountain operation sooner or later, because how can you guarantee the outcome of fountain operation in patients with LV dysfunction? The outcome is not guaranteed. And maybe heart transplantation might be the option for this patient rather than fountain conversion. And we are talking about the minimal RV function and size to maintain pulmonary circulation. But in fountain circulation, actually there is no pump. So if RV is there, maybe better than nothing. But in this patient, the patient did not tolerate because of the TR and PR. And double valve replacement for this patient may be an option rather than a fountain conversion. But actually the tissue valve failed test. That was the reason the patient condition deteriorated.
Okay, I think it's time to close this case. And yeah.